Hello everyone, welcome to our session, Use of Artificial Intelligence and Statistics in the World of Mental Health. We have two speakers today, Dr. Annie J. Lee and Dr. Sharon Lees Norman. Dr. Annie J. Lee is an assistant professor of neurological science in neurology uh, and Neurology's Center. Dr. Lee is a graduate of EWA Women's University in Seoul, Korea. She received an MS and PhD in biostatistics from Columbia, where she focused on developing statistical methods to understand neurodegenerative diseases using genomic and family history data. In research, Dr. Lee is focused on understanding neurodegenerative diseases, in particular Alzheimer's disease, multiple sclerosis, and Parkinson's disease, using advanced statistical approaches and large scale multiomics data. Next, our speaker is Dr. Sharon Lees Norman, who is a James Aldenstein Professor of Healthcare Policy, Biostatistics in the Department of Healthcare Policy at Harvard Medical School, and professor in the Department of Biostatistics at the Harvard School of Public Health. Dr. Norman's research focuses on the development of statistical methods of health services and outcomes research, primarily using Bayesian approaches, including the evaluation of medical devices in randomized and non-randomized settings for pre and post market assessments. Her application area, causal inference, providing profiling and evidence synthesis, item response therapy, and latent variable analysis. Let's welcome both the speakers. So uh, I don't see Annie still here. Oh, Annie is here. Oh,
Mhm.
let's go ahead, Annie. Welcome.
Thank you, Ranjita, for your thoughtful introduction and inviting me to the session. Hi, I'm Annie, and today I would like to share our recent novel machine learning method for disease subtyping using longitudinal clinical data and high-dimensional omics data. The motivation of our project was the heterogeneity among older adults in Alzheimer's disease, which suggests the existence of subgroups with distinct biological profiles and varying disease risk factors. So to identify these subgroups of people, the traditional approach is using clustering approach. So for example, unsupervised clustering approach such as k-means or hierarchical clustering cluster data points or subjects based on their similarities, such as distance. So if you look at this figure, we don't know that which groups they belong to, but we clustered their data points based on their distance, for example. So to give an example, using the brain transcriptomics data from the 3 brain regions. In our previous study, we applied the k-means clustering in each brain region's transcriptomic data, and we identified 2 groups of people in each brain regions. And using the integrative analysis, we identified overall 2 groups of people, with one having more steepest rate of cognitive decline than the other. And ApoE4 was associated with the more rapid cognitive decline in one group compared to the others. So we were surprised that considering the heterogeneity of Alzheimer's disease, that we only identified 2 groups of people. So while this unsupervised clustering approach is unbiased clustering approach, the limitation is that it may not capture clinically relevant subtypes. So this time, we thought about applying supervised clustering approach, which cluster data points guided by some known categories or outcome to predict which group a data point belongs to. So as you can see in this figure, for example, we have a pre-known knowledge of which these subjects belong to, whether they are cases and controls, and using this information, we can predict which group the data points or subject belongs to. So the existing method can be applied to identify groups of people using their clinical categories, clinical data or omics data. But the limitation is that this supervised clustering approach has been only developed for cross-sectional data, but not the longitudinal data. So in this project, we developed this novel machine learning supervised clustering approach to identify groups of people using the longitudinal clinical data and also using the high dimensional omics data. So just to give you an idea, we applied this novel method to the ROSEMap data, which is a longitudinal cohort study. And the goal was to identify groups of people, this time guided by longitudinal continuous outcomes. So we picked the longitudinal global cognitive function and also used the transcriptomic profiles in the dorsal prefrontal cortex in their brain. And specifically, instead of using the whole gene expression, we used the differentially expressed genes in pathological AD and adjusted for some Alzheimer's disease risk factors such as sex, ApoE4, longitudinal vascular risk factors such as hypertension, diabetes, stroke, and frailty. And we'll go over the results later, and I'll just try to go over the method briefly, which involves two steps. First is disease subtyping step, which we use the gene expression data, for example, omics data, to predict the cluster using a multinomial logistic regression. Since the gene expression is high dimensional, we apply the sparse lasso group regularization to select the specific gene expressions that is involved in the clustering process. And the second step, since it is supervised clustering, we re-identified and re-estimated those clusters, this time guided by some longitudinal outcome while adjusting for covariates. So through this model, since we are using longitudinal outcome, but also longitudinal covariates in the model, we can identify this time varying coefficient, rate of t. So we'll go over the results of these time varying coefficients as well. And to estimate this time varying coefficient, we use the B-splines and then and also apply this roughness penalty to handle the instability in this B-splines. So basically, we estimate these unknown parameters using the EM algorithm and use the bootstrap to estimate the 95% pointwise confidence interval of the time varying coefficients. So when applying to RoseMap cohort, we identify 4 groups of people guided by longitudinal global cognitive function. So as you can see in this demographic table, we identify 4 clusters of people, with cluster 1 having the lowest global cognitive function on average, which makes sense because it was guided by, clustering process was guided by this longitudinal global cognitive function. So if you look at the figure on the right, which shows the global cognitive function trajectory by cluster, you can see that the cluster 1 in red has started with the lowest global cognitive function at the earlier age, and it decreased more rapidly than the other clusters throughout the age, while cluster 4 in purple, they started with the highest cognitive function, so they're more resilient to Alzheimer's disease, and they decrease really slowly over that time. So if you, and when we try to look at the slope of this cognitive decline, and the figure box plot in the below, it shows this rate of the cognitive decline was the fastest and steepest rate of decline in cluster 1 in red, while the purple in cluster 4 was the slowest group. So if you go back to this demographic table, cluster 1 people also had a higher percentage of AD dementia and also higher percentage of stroke and frailty. And in the next slide, we'll go over whether these differences between clusters are significant or not. So to understand what makes these people different and to understand the characteristics of these people, we try to look at various traits. So on the y-axis of this heat map are the traits that we consider. So cognitive decline is what we I saw before. So it was the lowest in so each column is the different trade, and y-axis is the pairwise comparison of the clusters groups. So first column is cluster 1 versus 4. So as you can see, 1 had a fastest rate of decline, so it has the purple, which is a negative effect, while cluster 1 had a higher level of tau, amyloid, AD pathologies, basically, and also higher risk of AD dementia and pathological AD, and also having greater pathological hallmarks of AD, such as either TDP43, hippocampal cirrhosis, and also higher prevalence of ApoE4. So the box plots on the right shows that cluster 1 had a highest level of amyloid compared to like cluster 4, and similarly for tau accumulated most in cluster 1. So next step is understanding this effect of time-varying covariate on our outcome, which is global cognitive function. So each column is different vascular risk factor or covariates that we adjusted in the model, and two rows are cluster 1 and 4. So in cluster 1, we notice the participants who carries ApoE4 genotype, which is a risk factor for AD. Those people had a lower global cognitive function when their age was between 78 to 80. And cluster 1 people also, when they had a stroke, they had a lower global cognitive function when they were old, like over age of 92. And also when they also had frailty, they had lower global cognitive function when their age was between 85 and 92. So frailty is defined as a composite indicator of BMI, for fatigue, gait, grip strength, and physical activities. So our method also allows to not only identify clusters, but also allows to look at these effect of these covariate over the age. So since we use this gene expression to identify these clusters, this step, we try to understand whether the gene expression or pathways that distinguish these biological mechanisms for each group. So we conducted differential gene expression analysis and identified about the 6,000 gene expressions were differentially expressed in cluster 1 versus 4. And through the pathway analysis using gene ontology and enrichment analysis, we noticed that compared to cluster 4, cluster 1 people especially showed significant involvement in cellular transport, oxidative stress, microtubule stability, and intracellular trafficking, which dysfunction in these pathways are all known contributors to the pathological process of Alzheimer's disease. And since we use the same roadmap data so we compared our the clusters identified from two projects. So left are two clusters that we identify using 3 brain regions transcriptomic data, and right one is the 4 clusters that we identify using our current method. There was some overlap between some clusters, but the point is that we were able to identify more clear, distinct clusters of people in regards to their AD features. So as a conclusion, we developed the novel semi-parametric supervised clustering method that can be applied and used longitudinal clinical data while also using the just omics, one omics data. And we identify 4 groups of people that respond differently to certain vascular risk factors, like stroke and frailty that we observed. And also some clinical and pathological traits were different among the groups. And the future direction is to apply our method to other cohorts to validate. And also our next step is to apply more than one omics, so multi-omics, such as 2 different omics profiles by applying the multi-omics integrative analysis to identify disease subtypes. So I would like to acknowledge my first postdoc, Boyhu, and Dr. Yunja Wang in biostatistics, and Dr. Badri Vardarjan and Phil Dieger in neurology, and also appreciate our funding support. Thank you.
Thank you, Dr. Lee, for such a wonderful talk. Let's welcome our next speaker, Dr. Sharon Lees. We don't have time for questions right now. We will keep the questions for the end.
Okay, thank you. Let me share my screen. It says, okay.
Yeah, we can see your screen.
Okay. Okay. So thank you very much for the opportunity to present. I just want to go ahead and acknowledge some of my collaborators. I want to thank, I collaborate with some people from RAND Corporation in the US, psychiatrist Marcella Horvitz-Lennon, two statisticians, Dennis Agnil and Max Rubenstein, Larry Hahn, who's a statistician at Northeastern University, and several other collaborators within my department in healthcare policy. So I'm going to talk today in the context of a program of research I've been doing for several years in the area of people with schizophrenia. And these individuals have, it's a chronic disease, it's very disabling. And their main treatment involves antipsychotic drugs. And virtually anybody who has schizophrenia are going to be on antipsychotic drugs. It's going to be 95% of individuals are going to be on antipsychotic drugs. And so these drugs are taken over a lifetime. The drugs changes are going to be common. So they're going to be drug switches, and sometimes there's going to be polypharmacy. That is, individuals might take more than one type of antipsychotic drugs. And in the US, people who have schizophrenia, often they're going to be the costs of care for these individuals are going to be borne by the government. And that is public payers. And in the US, these insurers are called Medicare and Medicaid. And so the insurers are going to care for these people usually over their lifespan. And so today I'm going to talk about the care for individuals who are over 65 years of age. And we in the US really don't know much about the effectiveness of antipsychotics or even the efficacy of people who have schizophrenia who are over the age of 65. There have been clinical trials for people who are under 65 years of age, but little is known about the efficacy. And moreover, little study has been undertaken on the effectiveness of people who are over 65 years of age. And so little is known about the varying exposure intensity, whether that's dose or duration. And there's a lot of interest right now in the modifying effects of social context. There's a lot of interest in terms of social determinants of health, that is, the social, physical, and economic environments in which patients live, as well as race and ethnicity, and how those particular factors interact with the actual antipsychotic that the patient takes. That may seem a little odd, but the type of antipsychotic drug that a patient receives actually differs by the patient's race and ethnicity. And so what I'm going to talk today about is some type of research that we have taken in the past and that we're undertaking now to look at causal inference approaches for both the first type of antipsychotic drug that an individual with schizophrenia gets, or about particular treatment regimes to infer the average treatment effect or the average treatment effect on the treated or on subgroup effects among patients with schizophrenia. So to put it in context, right now we are looking at individuals in the US who are at least 66 years of age. I need 66 because I'm going to look back 12 months, so years. These are Medicare individuals. That means they're insured by the government, the US government. And we have about 46,000 individuals. And so hence their average age is about 78 years of age. 65% are females. And if you look at the distribution, there's about 13% Black, 6% Latinx, Others, that mean most of them are Asians, about 4%, and the majority are going to be white, 76%. And if I want to look at a context about their social determinants, let's say, about 60% get a low income subsidy. That means the government gives them extra money to help them out. Dual status, that means how much the states supply in terms of extra money. About half of them get that extra benefit. And if I want to look at the types of antipsychotic drugs they're getting, I'm only giving you a smattering of them. If I look at the cohort, there's about 22 different index. This is the first antipsychotic drug that they first get. There are 22 of them, and I just listed about the first, I don't even count 2, 4, 6, 7 drugs that I found based by the prevalence of them. The first 3 are quetiapine, risperidone, olanzapine. The first 6 account for 90% of the index fills. And so what we really want to study here are the effectiveness. And what we're going to look at is going to be mortality, drug discontinuation, psychiatric inpatient admissions, suicide attempts, and things such as that. So that's the context that we're looking at. And so what I want to talk a little bit about are some of the causal inference approaches that we want to use with these types of data. Obviously, this is an observational data setting. So in terms of prior work, we have looked at this question in a younger population, in a population of individuals that are 18 to 64 years of age. And if you think of the causal inference literature, there's been a lot of work in the context of binary treatments, whether you've got drug 1 or drug 2, for example. But there's been really sparse literature on multi-value treatments, that is, treatments where you have more than 2 drugs. And while you're going to look in the literature, you're going to see, yeah, people have looked at 3 or 4 treatments, but you really haven't seen a lot done in a practical way when you have 6 or 7 treatments. And so there's a sparse literature. And then even if you look at sort of there is, a theoretical, pieces on how you might deal with that. They're very practical implementations. And when you do look at most implementations, they usually are implemented as a series of binomial treatment assignments. And if you think about that, if you do a bunch of binomial treatments assignments, the sum of the probabilities aren't going to be 1. And there's some practical implementations if you do a series of binomial treatment implementations. And if you look at, for example, TMLE, target minimum loss place estimation, even that implementation uses binomial treatment assignments, and they don't really use a multinomial treatment assignment. And so the thought was, if you actually implement a true multinomial probability treatment assignment approach, you might gain some efficiency, because the joint modeling of multiple treatment categories is going to account for the correlations that's inherent when you have a multinomial treatment assignment probability. And so what we were interested in was the average treatment effect. And so if you think of the counterfactual notation, if I'm looking at the expected outcome for an individual assigned to treatment outcome assigned to treatment J versus had that person been assigned to treatment J prime, how can we actually estimate that? And so in prior work, and looking at that, if we wanted to look at TMLE for multi-valued treatments, and here we looked at 6 different antipsychotic treatments, and we applied that to this setting, again, in a younger, it was a younger population. And so if you think of TMLE in that setting, you can think of how do you estimate the outcome. This is the expected outcome. If you were to get treatment J, this is the usual thing that you would do from a targeted maximum likelihood estimator. You would estimate the first piece by superlearner. So the first piece you would estimate via superlearner the denominator, that's the treatment assignment probability, you would use superlearner. And the question is, in this first piece, is how do you estimate the epsilon hat? And the difference here is how one would do it if you assume a multinomial probability versus a binomial probability. The difference you can see is the second piece. And so the second piece here, if you use a multinomial versus a binomial, that's how they differ, basically. One is you're using a multinomial for the correction factor versus a binomial. And what we found is if you use the multinomial, you'll have better coverage. But surprisingly, the binomial approach often had smaller bias. And so it ended up, if you actually use the binomial piece, you had smaller bias, but not better coverage. So that was the first thing, which was somewhat surprising. The binomial approach needs a correction, but if you do use a multinomial approach, you do have better coverage. But I was surprised to find that the binomial approach did do a good job. Now, that's assuming a multinomial treatment assignment probability for the assignment of a multi-value treatment.
Dr.
And that's
Sharon,
assuming.
you have 2 minutes left.
Oh, okay. Did you say 2?
Yeah.
Okay. And the second approach, the second question was longitudinal treatment assignment for treatment regimes. And here we looked at 2 different drugs, olanzapine versus aripiprazole. And this was looking at diabetes risks in within 24 months. And, again, that was just 2 drugs. And this was looking at longitudinal treatment assignments. And here you have to use isotonic regression to ensure that the risk at month T is less than T plus 1. The question here is, we're working now, is how you extend this when you have more than just 2 treatment choices. Working now with when we have more than 2 treatments, you can see this. This is a mosaic plot of the sample of antipsychotics by race and ethnicity. And what you're going to see is we have very different sample sizes, as you can imagine. For example, with quetiapine, we have 15,000 individuals, but the distribution, as I mentioned, of drugs by race is very different. So paliperidone, there's only 489 individuals, and the distribution by race and ethnicity is very different. And you can, so we need to deal with that. And so what we're working on now is transfer learning for racial variation in the average treatment on the treated. And the idea here is that the target and source populations have very different outcome and risk factor distribution. So how can you use transfer learning to better estimate the outcome, the potential outcome differences for a race in a particular for a particular treatment? And so I'm going to conclude.
Sorry, Dr. Sharon.
Yeah.
The session is going to end. So.
Okay, I'll leave you with this. So a very interesting problem with
Yes.
causal inference techniques. So thank you very much.
Thank you so much for everyone. And sorry, I forgot to introduce myself. I'm Dr. Arinjita from Mark, working on this session. So thank you so much, everyone. And it was really a wonderful talk.